Is there a standard of care for treating smoldering multiple myeloma? Should high-risk smoldering multiple myeloma be treated? This video contains multiple opinions from multiple doctors and is for educational purposes only.
For an individual who is diagnosed with smoldering myeloma, coming to my clinic, one of the first questions patients ask is, what am I going to do next? Do I need treatment? And the answer is that at the current time, there is not yet any FDA-approved drug for the indication of smoldering myeloma. Looking at guidelines, looking at the NCCN guideline, looking at other myeloma working group guideline, all the guidelines have as the default to monitor the patient, to do a bone marrow biopsy, to do a PET-CT or whole body MRI, and to do blood tests. If all the workup excludes multiple myeloma, this would formally be a smoldering myeloma diagnosis. The guidelines would further recommend retesting the blood, say on a 3-month basis. If the marker stays stable, another year of about a 3-month interval would be the standard of care. Many times patients would consider doing a new bone marrow and maybe PET-CT or MRI after such an interval. And if that is confirmed again, sometimes the interval gets extended a little bit, so 3, 4, or even 6 months sometimes. If that's being done another year or 2, sometimes additional workup is done with biopsies or PET-CTs or MRI. And usually after 5 years or so of follow-up, patients will say, I feel confident. The guidelines would support that this does not look like a changing, progressing disease. Usually a 5-year window is going to predict the future. The history is usually a good predictor of the future, and that's what the guideline also suggests. Many times patients would do biopsy and imaging workup after that 5-year window and maybe do 6 or 12, even eventually month intervals for blood testing. I think with more sophisticated technologies with sequencing that I did mention before, that patient could be profiled upfront. You don't have to do all these workups and do all the blood work. You could much sooner identify if the disease is programmed to stay stable or if this is a disease that is programmed to progress. And you wouldn't have to go through all these different steps. But there is more work to be done before this will become the clinical standard of care. So for individuals that have the high risk, or sometimes also the intermediate risk, investigators have developed clinical trials for these patients. So depending on how these protocols have been written, different criteria have been set up to define eligible patients. So if a patient meets the eligibility criteria for a particular protocol, if that patient is interested in enrolling on that protocol and meets the criteria, the patient could go on. These are clinical trials. Most of these trials have as the primary endpoint to delay progression, or ultimately prevent progression. And usually they study the progression in relation to historical control. So if there's a delayed progression, they are trying to improve based on just monitoring. The criticism against these types of protocols is, for example, that we don't know if this is going to make a difference long term, because if the disease will happen anyway, it's just a matter of delaying it. If it comes back later and it turns into multiple myeloma, you will have to treat it anyway. And if you have stayed on therapy for a long time on the protocol, this would be years that you maybe didn't have to do therapy if you just chose to be monitored. But on the other hand, if the therapy is successful, if the protocol really is doing a good job, maybe the patient would not develop multiple myeloma. So these are, of course, very important questions, but we currently don't know the answer, which of these scenarios is the right answer. Also, there are toxicities associated with these therapies, and there are like a lot of practical things that come into play, all the inconvenience and things like that. Again, there are not yet any FDA-approved drugs. It's hard to counsel each and every patient. I think individuals have a different appetite for doing things early versus not. And I think there are some patients who really look to go on trials and they want to really take the opportunity. The last criticism I address also is that with more emerging data from genomic sequencing and other types of technologies, I think although an individual could be high risk with these retrospective models, if the disease is truly not biologically going to progress, another criticism against these trials is that you would treat the person that would not have progressed anyway, and the trial would then show that there is superior outcome with the intervention, but the reality is that the disease would not have progressed anyway. So these are very difficult questions, and I don't have the full answer for every person. I think it is an individual decision whether it's the right thing or not to go on the trial.
So again, this is a controversial question of should smoldering myeloma be treated or not. The difficulty with smoldering myeloma is that every patient's trajectory of smoldering myeloma is dramatically different. Some patients with smoldering myeloma, they're basically just MGUS, but instead of 5% plasma cells in the bone marrow, it's 11% plasma cells in the bone marrow. So I call them smoldering, but they will live for years and years and no problems. I've had other patients, and I've had them with smoldering myeloma, and we'll talk about the risk criteria, and I'm keeping an eye on them. I'm doing MRIs every 6 months and to really catch any spots in the bones, and still I missed a fracture, and it's happened to me in between 6-month scans. And so basically it's very hard for us to tell who in this umbrella diagnosis of smoldering myeloma, who is destined to have active myeloma and how quickly, and who is never going to have any symptoms whatsoever. We have risk criteria, and those of you listening to this will have heard my other question about the 2220 HR risk criteria. So if someone has 2 or more of them, meaning more than 20% plasma cells in the bone marrow, and spike greater than 2, a kappa to lambda, or lambda to kappa free light chain ratio more than 20, and or high-risk cytogenetic abnormalities in the chromosomes in the FISH report of the smoldering myeloma cells, I would call them high-risk smoldering myeloma. So for high-risk smoldering myeloma, the guidelines recommend discussion, basically, of what I would say of various options. There are treatment options that are potentially feasible in these patients. I should say, if someone has a separate problem, let's just carve that out. If someone has smoldering myeloma and also has unexplained neuropathy and a diagnosed AL amyloidosis, for example, they get treated. So this is assuming the smoldering myeloma is not causing some sort of separate disorder. In those particular patients, most patients that I've had in my practice still are observed. We observe them very quickly, very carefully. Gynecologists typically recommend blood work every 1 to 3 months. In my practice, I also do a bone marrow biopsy once a year. I do imaging every 6 to 12 months, head to toe imaging if I can, if the patient and insurance company will allow it, to make sure that if any spot emerges in any bones or a bone marrow with an MRI, I catch it like that. Are there treatment paradigms? So there are. Lenalidomide is an option by itself. There was a study showing that lenalidomide by itself, it was an American cooperative group study, showed that lenalidomide by itself, compared to not giving lenalidomide or Revlimid, did delay time to progression. So when these patients with smoldering myeloma became active myeloma, I'm not the biggest fan of that. Lenalidomide is expensive and has side effects, including a risk of second malignancies, and it can cause a lot of side effects for patients, like fatigue and so forth, and it can theoretically impair stem cell collection. So just doing it with just you and your doctor and nobody else is maybe a little bit less commonly done. I certainly have my colleagues in the field of myeloma experts who do that. I offer it to patients. It's not my preferred personal option. Luckily, many centers do have clinical trials open of various strategies to treat smoldering myeloma. There are studies of using quadruplets like DARA-KRD to treat smoldering myeloma. There are studies, there's a cooperative group study of DARA-RD versus RD, so daratumumab lenalidomide dex versus lenalidomide dex to treat smoldering myeloma. Dana-Farber in Boston has studies of actually immune therapies like teclistamab, a bispecific antibody, and CAR-T to treat smoldering myeloma. So I encourage patients to think about all the various options that are available. The guidelines cannot get over that critical part, that what the patient feels, the patient's values, the patient's concerns are kind of sacrosanct here, and I cannot make that decision for them. As I'm alluding to, I always discuss this. So if someone has high-risk smoldering myeloma, I discuss that your options range from a clinical trial to lenalidomide as standard of care just kind of by itself, which I don't typically recommend, versus close observation. Again, most of my patients in that category do still offer close observation, understandably so, but I have had patients who just, because of other risk factors, that they already have kidney disease or already have osteoporosis, or just their values that they really do not want this, they're concerned about it becoming active myeloma, or they have a family history of active myeloma, that they choose to intervene earlier, and the treatments do work. There's no doubt about that. The question is the safety and the side effects and the cost of them worth the efficacy that they demonstrate? So that, still an unanswered question we will try to find out. I'll briefly add, with teclistamab, just so the audience has heard it, teclistamab is a bispecific antibody. You'll hear about this, I'm sure, in other videos that you're watching. Teclistamab in smoldering myeloma absolutely causes side effects. You can have serious side effects. They have to go to the hospital, often to be monitored for cytokine release syndrome, fevers, and so forth. But just so you've heard it, in that study, in smoldering myeloma, the teclistamab had a 100% overall response rate, 100% rate of MRD negativity. Every patient who got the teclistamab, the myeloma was completely eradicated, the smoldering myeloma, I should say. Not necessarily cured, but wiped out. In active myeloma, when you use that exact same drug, exact same frequency and everything, it's more like 50-60% of patients have a response. And so probably these drugs work better in the smoldering myeloma setting because the cells are not that resistant. There's not as many clones of them and so forth. So again, it's very hard to compare apples to apples here. It's not a randomized study in any way or form, but I think with every year that passes, you'll see more and more literature in this space because we really, one, need to know who is going to have a risk of active myeloma, and two, what can we do that's maintaining efficacy. If we do decide to treat, how do we maintain that high bar for efficacy, but also keep things as safe as we can? Standard risk smoldering myeloma is controversial. I would not recommend treating that. There is, and I've seen studies that are pursuing very short courses of treatment, like 3 to 6 months of treatment to see if that can eradicate this clone. I mean, there's a precedent for it, right? Like if someone had a colonoscopy and you saw a polyp there, you wouldn't leave the polyp there, you just take it out because you're in there. So there is this idea of intervening on precancerous biology. Whether that applies to myeloma, especially in those patients where by proportion, statistically speaking, more of them will go their whole life without any side effects from the smoldering myeloma, and now you're considering giving them a drug that has side effects, there the risk-benefit ratio is a little bit more controversial, so I would not recommend that, and the guidelines do not recommend that. They, again, do recommend very careful observation. Different guidelines have different cadences for how frequently to do things. Again, in my practice, I do a bone marrow biopsy once a year regardless, especially for the first couple of years. And for standard risk myeloma, I do imaging once a year as well. Not an x-ray, but a whole body CAT scan or PET CT scan or MRI, just to make sure that nothing is evolving.
The treatment of high-risk smoldering myeloma, that is, I will tell you that in every single conference that you go to, or if you're lucky to go to any of our medical conferences, there will probably be a debate about whether to treat or not to treat smoldering myeloma, and that tells you everything about where the field is right now. This is very controversial, but at the same time, I think we're starting to learn so much more about defining who that population is, and I think that's the first step, is that still is a little bit of a moving target. It's hard to know exactly who those patients that benefit from treatment are. I think we have some good ideas and certain ways to assess who may be high risk enough, who has that risk of transforming to active myeloma over the next 2 years. And we define high risk as a 50% risk of transforming to active myeloma. And those patients are the ones that we know are likely to benefit from therapy. The problem is that within that group, there's still a lot of heterogeneity, and there's still a lot of factors that are not taken into account. And so because we don't all agree on who that high-risk population is, it makes it difficult to say to any one person, you're the one who needs to be treated. But I think there's very good data that if we were able to say you are definitely going to become active, that I think I would recommend that you be treated. It's just that I don't know who that person is right now with that much certainty.
So the first thing that we've noticed in high-risk smoldering myeloma is that there are 2 large randomized studies that actually showed that indeed treatment is better than observation. And these were the lenalidomide and dexamethasone study by the Spanish group, as well as the lenalidomide alone versus observation by the ECOG study by Sagar Lonial. Those two were wonderful because for the first time, we understand that if you treat early, you can actually make a difference in progression-free survival, and in one of them, in overall survival. The problem is the criteria of what is considered high-risk smoldering. So both studies use very different criteria. One of them even included intermediate and low-risk smoldering myeloma. So we really don't know the true answer of who are the patients who will benefit the most from this intervention. The second question is, well, should we really treat very high-risk patients with single-agent lenalidomide? Is that okay or not? Because if you just said that smoldering myeloma, extremely high risk, looks like myeloma, I don't want to treat myeloma with only one drug. If I'm going to intervene, I want to intervene with everything I have, which is 3 drugs, even 4 drugs now, so that I do not cause clonal resistance. I do not cause worsening of the disease. So there is a hesitation of using this as a standard of care. I think it's a very good first step. It's a proof of concept, but let's improve on it before we consider it a standard of care.
Should high-risk smoldering multiple myeloma patients receive therapy? In my opinion, this should not occur outside a well-designed clinical trial. There have been 2 trials that have been completed in patients with high-risk smoldering multiple myeloma, but they suffer from a number of defects. In the first trial, which is now quite old, patients who were admitted to the trial did not have the studies that are usually done today, such as a PET scan or an MRI. As a consequence, some patients in the trial may have had actual active myeloma. And so now we're comparing treatment versus no treatment in a patient population that includes active myeloma. In addition, trials have demonstrated that there's survival benefit, but one of the issues is that patients who were elected not to be treated with high-risk smoldering multiple myeloma were observed even in the face of a rising protein, and that doesn't conform to current practice. The second trial has shown an improved time without myeloma, but has not demonstrated a survival benefit. I think understanding the biology of high-risk smoldering multiple myeloma is important, and by that I mean patients who are destined to develop multiple myeloma with at least a 50% risk within 2 years. But in order to be treated, I believe they should go on to a well-designed clinical trial. I'm also concerned that less intensive treatments for smoldering myeloma patients may select out more aggressive multiple myeloma populations that could put them at risk. And so in the context of a well-designed clinical trial, I think it's completely appropriate to participate. But I think outside of a clinical trial, high-risk smoldering myeloma requires an expert in multiple myeloma to assess whether it would be appropriate to intervene. But my general answer would be no.